Hi, everybody. Good afternoon, and thank you for joining us with our third COVID conversation program designed to prepare California for the COVID-19 immunizations. Today, we are fortunate to have Dr. Peter Hotez with us. Next slide. So this is going to be a relatively informal conversation with Dr. Hotez, and we are going to do primarily questions and answers. All the lines are muted for the duration, and Dr. Pannaraj and I will be the moderators for this discussion. You can communicate with us through the question and answer box located on the right side of your screen. And if you have any technical difficulties during the webinar, you can leave a note in the chat box. You can see where the question and answers bar is, and please leave a question and we will get to as many questions as we can. This presentation is brought to you by the California Immunization Coalition. We are a nonprofit public-private partnership dedicated to achieving and maintaining full immunization protection for all Californians, as well as the American Academy of Pediatrics in California, which is a partnership of the 4 local California AAP chapters committed to obtaining optimal physical and mental well-being of children. Our moderators today are me. I'm a primary care pediatrician with the CHOC Primary Care Network in Orange County, and Dr. Pia Pannaraj, who is an associate professor of pediatrics at the CIC School of Medicine at USC, and is a infectious disease doctor at the Children's Hospital of Los Angeles. And together we are the co-chairs of the Emerging Issues Committee of the California Immunization Coalition. And then I have the honor of introducing our panelist today is Dr. Peter Hotez, who many of you know well. He's a professor of pediatrics and molecular virology at the Baylor College of Medicine. He's also the co-director of the Texas Children's Center for Vaccine Development and endowed chair in tropical pediatrics. He's a vaccine scientist who's currently working on a COVID-19 vaccine of his own. He is an acclaimed author and an amazing advocate for vaccines. You guys have probably read his book, Vaccines Did Not Cause Rachel's Autism, which is amazing, and it's a really great read, a very personal story, which I highly recommend. And coming out on March 2nd is his next book, Preventing the Next Pandemic, Vaccine Diplomacy in a Time of Anti-Science, which is largely what we're going to talk about today. And with that, I'm going to pass this on to Dr. Pannaraj, who will start our conversation.
Hi, wonderful. Thank you, Dr. Hotez, for joining us today, and thank you to the audience for joining us. It seems like we should start with a summary of what's gone on so far with this pandemic and where are we headed, especially now that we have several vaccines coming out. Please go ahead.
Yeah, well, thanks so much for having me back. I was with you in person, I guess it was 2 years ago, 2019, and sorry I'm here only virtually this time, but we'll make it an aspirational goal for me to come fully back maybe a year or two from now. What's happened now with COVID-19 is the number of new cases is starting to decrease. That's good news. You know, we hit a high of around 250,000 new cases a day, which those are confirmed cases, so the number is really closer to 1 million new cases a day, a pretty horrible acceleration after the Thanksgiving, Christmas, and New Year's holiday. Now it's gone down. It's now below 100,000 new cases a day. Still a pretty high level. You know, if we were looking at last summer, we'd be quite alarmed, but it is good that it is now going down, except for some parts of the country. So in West Texas, South Texas, it's still pretty screaming high, but overall it is going down. The bad news is now the new variants are here, at least with the UK variant, one from the United Kingdom, that is rapidly taking over. So there was a paper that came out over the weekend or the week from the Scripps Institute in La Jolla, California, just looking at San Diego and looking at a lot of other virus genomic sequencing of various virus isolates. And the numbers suggest that it's going up pretty rapidly, and their estimates are roughly a doubling every week to 10 days. So what that means is even though we think the UK variant is still relatively infrequent. That's going to change rapidly. So the prediction is by the spring, the UK variant could become dominant in the United States. And the reason we have to be worried about that is the evidence show that this new variant has a higher reproductive number, is more transmissible than what we're used to. And there's some evidence, although not as firm, but some evidence that also the severity of illness caused by this UK variant is increased as well. So with an increase in mortality rate. So we're could be looking at a pretty grim spring as the numbers really start to accelerate. And there is some good news on the horizon. We do have the 2 mRNA vaccines. The not so good news is whether that vaccine supply is going to be adequate as we head into the spring. We know, for instance, that Novavax is committed to 100 million more doses by June or July. Same with Johnson & Johnson and their vaccine. And we know the Moderna and Pfizer have committed to additional mRNA vaccine by the summer or fall. But you keep hearing what I'm saying, June, July, August. How do we now navigate the next few months? How do we get through February, March, and April? To me, that's my biggest concern, and what keeps me up at night is while we're doing, I think the Biden administration is now starting to open up additional hubs beyond the pharmacy chains, beyond the hospital chains, and looking at things like outdoor football stadiums from the NFL and other big open air venues. I think that's great that he's doing that. And the federal government has a plan in place to start vaccinating the American people. To me, the unknown is the adequate levels of supply for this transition period from March until May, and that is the big unknown. On top of that, we do have this problem with substantial amount of COVID-19 vaccine hesitancy, and the Q&A we'll talk about that. But with those general starting comments, why don't we just go right into the questions and then in our moderated discussion, however you'd like to proceed.
Yeah, so if we're basically in a race now between the vaccine and the variants, do you think there's some strategies that we could use to make our limited supply last longer? For example, delaying second doses, preferentially giving the non-mRNA vaccines to younger people rather than the older population?
Yeah, I think there are some strategies out there. My friend and colleague Mike Osterholm is a big proponent of delaying the second dose and trying to get as many people immunized with a single dose of the mRNA vaccines as possible. I don't have all of the data in hand to really make a sound assessment of that. At first glance, I'm not enthusiastic, in part because I think there's too much variability in the protection afforded by a single dose of the mRNA vaccine. Looking back at the first, the phase 1, phase 2 trial, what I tended to see was a lot of variability in virus neutralizing antibody, with some people having lots of it, meaning they're protected, others not having much at all. So all of the data says partial protection. I'm worried that what it really means is some yes, others no, and so it gets amortized to partial protection. And to get protection against the South African variant, you need really high levels of virus neutralizing antibody against the original strain to begin with. And I'm worried you won't see that with the single dose. So, and I don't know about the UK strain. So from all those reasons, I tend to favor keeping things intact with the 2 doses of the mRNA vaccine, depending on what's available and what the supply chain looks like. And I just don't have I'm hearing different things from different people about what that really means. So if that's not on the table and we're not going to have substantial amount of J&J and Novavax and the other vaccines out there, what are the alternatives? I think one possibility is the AstraZeneca Oxford vaccine, which we heard over the weekend is not protecting against the South African variant, but that's not here in a big way. It is protecting against the UK variant. And if we are sitting on tens of millions of doses, is there an opportunity to start releasing that vaccine now? It was recently authorized by the European Medicine Agencies, the EMA, which is a regulatory authority about at the same level as the FDA for the European Union. Looking at European data, the US FDA is holding off pending review of US clinical trials. But to me, that's one place we potentially can move. If we have substantial numbers of doses, and I'm hearing anywhere from 30 to 50 million doses, but that are available, I just don't know that for a fact. And so we're just not getting a lot of detailed information on what's around. And then we're hearing some reports that it may not protect that well against older individuals over the age of 65, and that may or may not be true. But if it is, then my point would be, well, if it still works for people between the ages of 20 and 40, better to have it in people's arms than sitting in a refrigerator or a warehouse someplace, because as we can scale up and get more young people vaccinated, that would still potentially have an impact on reducing transmission, so there would not be a downside. So that's kind of an example of the out of the box things we might have to think about if the variants really race ahead, as many of us predict, and we're out of other options. But for full transparency, I've not had any detailed discussions with people in the Biden administration about what we have in the freezer, in the refrigerator, or what are the levers we can pull and push. But I do think we need to give some thought to all of these things.
Thank you. We have a question from the audience about the variants that have emerged. Do you believe that the most concerning variants have already emerged? Or are we likely to see more mutations as the pandemic goes on? And also, with that in mind, how do you counsel providers to talk to their patients about the vaccine, given that there's a lot of questions about new variants and protection against those variants?
Well, I think the first off is all of the vaccines seem to so far work against the UK variants. So, and that's the one that's starting to emerge as becoming dominant. So I think providing some reassurance. The more troublesome one is the South African variant, which the two mRNA vaccines and the Novavax vaccine, the Johnson & Johnson vaccine, don't appear to protect as well, but they're partially protected. The good news is right now we don't think they're widespread. We do know there were these two individuals in South Carolina with it, and these are individuals who have not traveled, so we know it's here. The question then is, how widespread is it? And we don't think it's widespread. On the other hand, we've underperformed in terms of whole virus genome sequencing. We should be at about 10 million virus genome sequence, so we know we can map all of the variants and how extensive they are, but we've probably done under 100,000 or a fraction of the 10 million that we should have. So there is a possibility that the South African variant, which is in South Carolina now, may be more widespread than we think. And so that's got to be a big priority as well, as stepping up virus genome sequencing. So the reassuring news is the one variant that we know is here in a big way, the UK variant, seems to be susceptible to the vaccines. The not so good news is how quickly we can race ahead of the variant in terms of vaccinating the American people. And we will have to deal with the South African variant down the line, and that may require us to design additional boosters. In other words, so go ahead, get the 2 doses of all of the different vaccines, protect yourself against the original variant, original lineages that are already here in the US and the UK variant, but be mindful that later on in the year or next year, you might need a 3rd immunization as a booster, and maybe get people ready for that possibility. We don't know that for certain. There's certainly not been any guidance documents issued by the FDA, but that is a possibility that we ought to think about.
There was a add-on question related to that. So Dr. Hotez mentioned that inoculating 20 to 40-year-olds might reduce transmission. Has it been established that transmissibility is correlated with vaccination? And my corollary question to that is from my mother-in-law, who was vaccinated fully, as are many of her friends, and she wants to know whether she could play bridge with them again.
Yeah, no, all good questions. Yeah, how much young people contribute to transmission still requires additional study. Some feel that it's the young adults that are contributing the lion's share of transmission, so that if you could potentially vaccinate them and keep them out of the bars and doing things that 20 to 40-year-olds do, that could go a long way to reducing transmission. And since we've seen over Super Bowl weekend how difficult it is to keep people between the ages of 20 and 40 down, that would be nice to be able to have them vaccinated. In terms of your mother-in-law, you know, one thing I tell people is if they've had 2 doses of the Moderna or the Pfizer vaccine and waited about a week afterwards to get really high levels of virus neutralizing antibodies, those virus neutralizing antibodies are going to keep you out of the hospital and will keep you out of the ICU. They're 95% protective and, you know, even higher potentially against serious infection. So you definitely have some comfort zone about getting your life back. Keep in mind, we do not have the evidence showing that the vaccine stops asymptomatic transmission yet. I think it will have a substantial increase based on non-human primate studies showing that the vaccines dramatically reduce the amount of virus shedding from your nose and mouth, and that's what we mean by asymptomatic transmission. But we just don't have the hard evidence yet. So that if your mother-in-law, you know, I don't know how old she is, let's say 70s or you know, somewhere between the ages of 60s and 90s, she can have some comfort level knowing she's not going to the hospital from COVID-19. On the other hand, if she's exposed to the virus, potentially she could still have asymptomatic infection, as could her friends if they're all vaccinated. But, you know, at some point, we're going to have to, I think, you know, find some way to let people get back to a normal level of life. So the risk is not zero, but certainly I would feel comfortable if I were vaccinated being in close quarters with another person who's also vaccinated. So if everybody's vaccinated, I think there can be some comfort level there. But keep in mind, if once you leave that place, you potentially could be shedding virus. So if you're going to be associating with people who are not vaccinated, there is risk you could transmit that virus to somebody else. And I hope I've thoroughly confused everybody now by that answer. So the bottom line is, if you're vaccinated, you are protected against serious illness, will not go to the hospital or the ICU. However, you potentially could be shedding virus to other people. So let me give you a couple of examples. So I'm living with my wife, Ann, and my youngest daughter who has special needs. So when I was vaccinated first because I'm part of a healthcare system, got the 2 doses and antibody, I knew I had a comfort level knowing I'm not going to the ICU or the hospital. However, if I'm in the workplace and get exposed to virus, potentially I could be infected, not symptomatic, but infected, shedding that virus and bring it home. And since my wife Ann takes Humira for an autoimmune condition, she potentially could be vulnerable to infection if she's not vaccinated. Therefore, even though after I was vaccinated, because she wasn't, I had to pretty much behave as though I weren't vaccinated. Let me give you another example. So now let's say these are real life examples. Now let's say Ann gets the 2 doses of vaccine. We live in Texas. She hasn't seen her mother-in-law in a year. She wants to go visit her mother-in-law, but in New Jersey, they're not doing a very good job of vaccinating. So she's 82 and unvaccinated. in theory, if she goes to visit her mother-in-law by flying on a plane, there is some risk that she could be transmitting the virus to her mother-in-law. Now, eventually we'll have data, I think, that will show that when people are vaccinated, they are not going to be shedding virus to a depreciable extent, but we don't know that for certain yet. So we just don't have the data. So those are kinds of some game modeling situations that we could kind of go back and forth on. Another example, so let's say Ann and I are vaccinated, and we haven't seen our 2 adult kids in a year. So my daughter is an assistant professor at UCLA, and my oldest son is in Tucson, Arizona, is a reggae and ska musician. Don't ask, we're not going to go there today. But we'd like to see them. And maybe we could all meet in Tucson. So Emily could, with her husband, could drive from LA to Tucson. She's vaccinated, he's not. And Matthew and his wife Brooke have had COVID. So maybe they're resistant for a while. In principle, they could still be, all of us could still be shedding virus. So we have to, so there is still some risk, but the fact that we're vaccinated, they've been recently infected, Emily's been vaccinated, the only odd person out is her husband who's not been, so he's at risk.
Great, thank you for that. What are your thoughts around school opening? That is a hot topic amongst pediatricians. We have to keep in mind both the children and the teachers. Now, teachers are up next. Teachers and school administrators are up pretty soon in terms of the tiers for priority of getting vaccines. But we do have a lot of hesitancy around teachers as well, that, many of them don't want to get the vaccine. And so they may be against having schools reopen. We're curious, what are your thoughts about that?
Yeah, I mean, what I've been hearing more is from teachers who are upset that they're not getting vaccinated and they want access to the vaccine, and they feel they're being put in this compromising position of going back to school and are at risk for COVID-19 and its consequences. So let's unpack it a bit. First of all, last summer I was on Zoom calls like this with school boards, with school superintendents, with teachers, because they were very concerned. What they were doing in Texas, in Houston, was they were being very innovative with use of plexiglass. They were really adhering close to CDC guidelines. Very worried, very scared. Everyone was wearing masks, but they went through it. And it turned out that the fall school year went better than I would have thought. That the amount of serious COVID among teachers was not zero, but it was very modest. So by adhering to all of those strict standards, things went better than I would have predicted given the level of transmission. Point one. Now the vaccines are here. And the question is, are we pushing it too hard? I mean, are we pressing our luck? So, with everyone being so vigilant last fall, we kind of got away with it. So, this, in theory, you could say, well, let's just repeat that performance. I'm not terribly comfortable. I would feel so much better if teachers and staff were vaccinated and the parents. So, especially those who are at risk because of age or comorbidities. And I'm pretty confident by next fall that will be the case. That we'll have teachers and staff vaccinated. Even if the kids aren't yet by the fall, I still think we can have a pretty good school year. And maybe we'll even have interrupted virus transmission right then. So you might saying, well, Dr. Hotez, you just answered every question except the one I asked you, which is what happens in the spring? And that's a tough one. And so Rochelle Walensky, the CDC director, made a pretty strong statement that, schools have to reopen. Then there was a bit of backpedaling. I think she meant well. I think she was a bit inartful on how that statement was made. No question that we need to do a better job vaccinating school teachers. And for me, that's got to be a priority right now. And I think any teacher who feels uncomfortable being in a classroom right now has that right to be uncomfortable, particularly if they have risk factors, and work as hard as we can to get those individuals vaccinated and as fast as we can.
I'm going to continue with the school theme. We've had a lot of questions about children being vaccinated, and we've heard from a lot of teachers who are reluctant to go back until they're vaccinated and their students are vaccinated. Do you know of any trials being done in children under 12? Is that happening yet? Do you think they will get vaccinated in the end?
I think they might. The clinical trials are underway for the 2 mRNA vaccines, and we're looking at a pediatric trial for recombinant protein, a recombinant protein vaccine in India. I think the adolescents will have that data first, and so it may start out with the high school students and the junior high school students being vaccinated first, and it may be a little while before the little kids are vaccinated. I think I think if teachers and staff are vaccinated, and especially if parents are vaccinated as well, I think we can move forward in a pretty robust way. And it may be a while before the kids are vaccinated. So it may be that by the fall, some of the adolescents may be vaccinated. I just don't know about the little kids by that time. Certainly not this spring.
Can you talk a little bit about the concerns in pediatrics, the reasons why they're going down step by step? Right now, 12 years, they're starting to do the trials 12 years and older, and then they'll go lower, and any risk for a MIS-C-like syndrome after vaccination for the younger kids?
Well, I think this is one of the reasons we're doing clinical trials, because we don't know, we cannot always assume that the full safety performance that we're seeing in adults is reproducible in kids. And that's why we tend to proceed conservatively with the idea that you do the older kids first, the adolescents, thinking they'll more resemble the adult immunological profile, and then you go to the little kids. And so we'll get that safety data, I hope, in the next few months among the adolescents, say 12 to 16. And if you remember, when the Pfizer vaccine was first released, there was some disagreement on whether that vaccine should have been authorized only for those under the age of 18 or should include the 16 to 18-year-olds. So there wasn't complete consensus on that. I think we'll have a lot more clarity after those adolescent trials. In terms of the multi-system inflammatory syndrome, exactly, we don't really understand the full basis of that. Fortunately, it seems to be a rare condition. It does resemble somewhat clinically what we knew as Kawasaki's syndrome. What was interesting about that was, when you looked at some of the older literature, there were a number of papers postulating that Kawasaki's syndrome was actually due to coronavirus infection. So I thought that was, and there were some clinical trials done, clinical studies done that didn't really bear that out, but it was interesting that observation had been made before. So does it occur, and it seems to occur in a time frame that suggests that it's occurring late in the illness after individuals have antibodies on board. So we'll see. Hopefully not. Hopefully, this will not trigger Kawasaki's, that it's not due to some kind of antibody-dependent enhancement. But again, this is why we are not proceeding rapidly. The question I'm surprised you didn't ask was about pregnancy, which is the one that often comes up. And during the clinical trials, if you were known to be pregnant or tested positive for pregnancy, you were excluded from the participating in the clinical trial, so we don't have the full range of data for pregnant women, but was noted that several women during the phase 3 clinical trials of these vaccines did become pregnant with so far no untoward effect. And so then the question is, how do you proceed? And you know, I think one of the big considerations is the fact that pregnant women don't do well with this virus, getting the COVID-19 virus. We have high rates of ICU admissions and even deaths. So accordingly, the American College of Obstetrics and Gynecology now recommends for pregnant women and breastfeeding women to get the COVID-19 vaccine, knowing that this has not been fully studied. So it's really a matter of evaluating risk versus benefit. So if it were my daughter or sister or family member who was pregnant, I would recommend strongly that they get vaccinated. The other advantage is maternal antibodies to the vaccine could potentially pass to the unborn baby through maternal fetal transfer across the placenta, so that the baby, the newborn baby, will be born having some antibody titers against this virus, and that may also further protect the baby, at least for the first few months. And we do have some examples of that, and for vaccinating moms in order to create maternal antibodies that passively protect the baby. We've done this now for whooping cough, we've done it for tetanus, done it for influenza, and it seems to be an effective strategy, and that may be the case also for COVID-19 vaccines.
I want to use this discussion about pregnancy to kind of shift gears a little bit and talk about vaccine hesitancy and misinformation, because that's one of many falsehoods that we hear on a daily basis in our clinic. And, you know, as vaccine advocates, we deal with misinformation all the time, and we were talking about this stuff before everybody else did. And I'm curious about your thoughts of how you think we should approach our patients who have these questions that are frankly not true. And I'll give you a few examples of things that I've heard just in the last few days. So
I just want to see if you can come up with one that I haven't heard before.
I'm sure you've heard them all. So, you know,
let me just say in general, I think my approach is to be sympathetic for the simple reason that we've, you know, as a community, the pediatric societies and the federal government and even the academic health centers have really not shown any appetite to take down the misinformation or the targeted disinformation campaign. And it's important to remember that the anti-vaccine information dominates the internet. By some accounts, there are almost 580 fake anti-vaccine websites, all revved up on social media sites. If you go to Amazon.com and type books up at the top, and as everyone has done, press return, you'll get the health, fitness, and dieting in a column at the left. You click, you can do this now, you click on that, you'll get the books on vaccination. You click on the books on vaccination, they're pretty much all fake anti-vaccine COVID conspiracy books, including several that say that the way to address the autism epidemic is to get rid of me and to get rid of Stan Plotkin, who's a beloved colleague. And so these are very aggressive groups. They're monetizing the internet, both through advertising and selling fake nutritional supplements, selling fake autism cures, peddling the fake books on Amazon. This is a multi-billion-dollar industry. And these parents are the victims of it, because, you know, when you're trying to download credible, this is even before COVID, about credible information about vaccines, more often than not, you're going to download garbage. And this is something that pediatricians have to face, that parents are coming into your office with a lot of bizarre ideas, and they themselves are the victim of this misinformation / disinformation campaign. The misinformation, the difference being disinformation implies intent, that parents are being deliberately targeted. So this was true prior to COVID-19. It ranged everything from vaccines cause autism. Then they really targeted the HPV vaccine and said it caused autoimmunity, it caused infertility, it caused miscarriage, it caused multiple sclerosis. And if you notice, some of the language around COVID-19 vaccines, they're pretty lazy. The anti-vaccine people basically just copy pasted from what they were saying about HPV vaccine, and now, because they can't really get away with autism if you're vaccinating adults, so they just copy pasted what they found from HPV vaccine and applied it to COVID-19. So you'll see a lot of similarities in the language, and so that's my preface. So go ahead, let's hear what you're hearing these days.
Well, the one thing that I hear a lot, and this is, unfortunate, right? So we're vaccinating tens of millions of older people every month now. And, when you take a cohort of tens of millions of older people, some of them are going to die for various reasons. So Hank Aaron was big in the news, right? Because he got his COVID vaccine and died like 2 weeks later. And I heard that from many patients. How do you recommend having that discussion with either families face-to-face or via social media about these, correlation does not equal causation conversations?
Yeah, I first of all, I try not to have the conversation on social media if you don't have to, because it's just a rabbit hole. I mean, I'm on social media a lot on Twitter, but I use it to highlight papers that I've written or important information from colleagues. I tend not to go down the rabbit hole of getting into Twitter fights with people. And I'm always reminded of Lady Gaga's immortal words that social media is the toilet of the internet. And it's good to keep that in mind and not to get into that down that path too much, because it's just a huge time sink. So I think this is really a problem. So let's go into the Henry Aaron story. And I'm a big baseball fan, and so I was very saddened to hear about the news of Henry Aaron. And I think I remind people that if you look at the number of Americans who lose their life over the age of 65 every week, it's in the millions. And so once you're vaccinating millions of Americans over the age of 65, some of them will lose their life in the following week. That's inevitable and nothing to do with the vaccination. So that's not an easy message to transmit. So for instance, we heard about 29 deaths in Norwegian nursing homes over the week after vaccination. Well, it turns out that the estimate is 400 Norwegians die in nursing homes every week over the age of, I think, 75. And if they happen to be vaccinated, they're just going to die after vaccination. So I think that sometimes is helpful. But of course, the anti-vaccine people are never ones to take the high road. So right as that happened, there was the websites and the social media messages were the cause and effect that Henry Aaron's death was due to getting vaccinated. It didn't help in the fact that he got vaccinated in a very high-profile way, which was to encourage African Americans to get vaccinated. He did it in a very public manner with Andrew Young, I think, from a U.S. ambassador to the United Nations, and someone else, I think, maybe a member of the clergy, and that was to his credit. But there was that tragedy, but there's no evidence that was related to getting vaccinated.
I get asked a lot, which vaccine should I get, Pfizer or Moderna? And soon there'll be Pfizer, Moderna, J&J, or AstraZeneca. And some people say, oh, well, maybe I just want to wait and see what happens, and then I'll get vaccinated later. How do you respond to those questions?
What I say is, look, but especially with UK variants here, this is going to be a deadly surge. And the only way you can guarantee that you're not going to go to the hospital or the ICU is having virus neutralizing antibodies in your system. And that's how all of these vaccines work. They all even though they're different platforms, different delivery mechanisms, whether it's mRNA or adenovirus or recombinant protein vaccines or particle vaccines, they all work by inducing high levels of virus neutralizing antibody. And these are studies that we showed over the last decade working on coronavirus vaccines. So it's all about figuring out the best way to deliver the spike protein. And because they all work by the same way and they all induce, at least the ones through Operation Warp Speed, induce high levels of virus neutralizing antibody, take whatever you can get. It doesn't matter. They will all save your life. The one thing I do say is with regards to the Russian Gamaleya vaccine, if you're traveling abroad, or a couple of the Chinese vaccines, the Sinovac, CanSino Bio, those seem to induce much lower levels of virus neutralizing antibody. Still enough to cause protection, but probably are not going to work. They may not work against the South African variant. So, for instance, I was on a Zoom call like this with a large corporation that has a big presence all over the world, and their employees, sometimes that's all they're offered are the Russian vaccines or the Chinese vaccines. My response is, if that's all you have as an option, get it, but recognize, it's better than nothing, but recognize you probably need a boost as soon as you get to Europe and the US if you're eligible.
I think I'd be remiss if I didn't ask you about your COVID vaccine. So as you talk about in Vaccines That Not Cause Rachel's Autism, you talk about your career and your real passion for the health of neglected populations and people who don't live in countries like the United States. And can you tell us a little bit about the low-cost vaccine that your team is working on?
Yeah, so we've been, I've devoted my life, I'm an MD, PhD vaccine scientist, devoted my life to developing vaccines mostly for poverty-related diseases, making vaccines that the big pharma companies would make because they're for diseases of the world's poorest people. So we have a vaccine for schistosomiasis, which is an important parasitic cause of genital urinary disease among women in Africa. We have a Chagas disease vaccine, which is a disease of extreme poverty in Latin America, and those are moving through clinical trials. And then we adopted a coronavirus vaccine program about a decade ago for SARS and MERS for the same reason nobody cared about coronavirus vaccines back then. Then something changed in January, and we saw the COVID-19 sequence quickly pivoted, and now we have a low-cost, which we think $1.50 a dose, recombinant protein COVID-19 vaccine that's being scaled up across India with one of the big pharmaceutical producers in India known as Biological E. They are supplying a lot of global health vaccines for the world. They've now taken a license for our vaccine, not exclusively, and they're now scaling it up to make 1 billion doses. So that's very exciting. So that's going through clinical testing, and we hope we can make a contribution as a low-cost recombinant protein COVID vaccine, because we're running out of options for Africa, Asia, and Latin America, because the mRNA vaccines are probably not going to be scaled sufficiently to have those have a major role. And that we've talked about the problem already with the Russian and some of the Chinese vaccines. And now Merck has dropped out, Sanofi is delayed. So when you start going down the list, you realize there are not that many options out there for low and middle income countries. And so hopefully ours will be one of them and make that contribution. We'd love to get it into the US as well, because our vaccine uses the same technology used to make the recombinant hepatitis B vaccine that's been around for almost 40 years, and it's been used to vaccinate infants and kids for years. And it uses the same microbial fermentation technology and yeast. And if parents are skittish about mRNA or adenovirus vaccines for their kids, wouldn't it be great to have this as an option? So we're seeing if we can talk to some investor groups about coming into the US, but it's not an easy it's not easy with all the other vaccines out there already.
That's wonderful. Once we have your vaccine, or even with the vaccines now, what suggestions do you have to help make sure that the vaccines are distributed with equity across all race, ethnicity, income level, both here in the United States and elsewhere in low and middle income countries?
Yeah, here in the United States, we've seen how this virus disproportionately affects Hispanic and Black and Native American communities. And we're seeing now that this vaccine is, this virus, about a third of the deaths under the age of, a third of the deaths from COVID-19 in Black and Brown communities, about a third of the deaths are occurring under the age of 65. So, this narrative that the virus is only affecting older Americans 70 and up is not true for the Hispanic and African American and Native American community. So we're seeing a lot of moms and dads in their 40s and 50s losing their life from this. And this makes it all the more important that we get those groups vaccinated. And that's why I don't like these rules of 65 and older, because it doesn't really address the fact that, a third of the US is Black, Brown, and Native American. And we need to lower that age group to say, and I don't know exactly whether it would be 45 or 50, but that's an important message, I think. And the other way around this, of course, is to open up more hubs in low-income communities, and that's going to be really important as well. And I know the Biden administration is committed to that. The way this started out was to focus on the pharmacy chains and the hospital chains, and it was great that the big chain pharmacies like CVS and Rite Aid stepped up. But the problem is in some of the low-income neighborhoods, many of these are pharmacy deserts, or in the community hospitals have closed. And so how do you ensure access? And I think that's something that really needs to be emphasized more. So opening up more community health centers for vaccinating, and some of the big outdoor stadiums. We don't really have a good system in place for adult vaccinations. I don't know about you, but I get all my adult vaccinations at the pharmacy. I got my Tdap, my MMR booster, my Shingrix at pharmacies, and that worked well for me and my family. But for a lot of low-income neighborhoods, it's just not really an attractive option.
Where do you think this is going? So, in other words, what do you think? When do you think we'll be out of this, if we're ever out of it? Will my kids go to school in the fall? Will I be wearing a mask, talking to you next year? What do you think is going to happen?
I've devoted my life to working on something called neglected diseases. So by definition, I'm one of the more optimistic people you'll talk to. So I am optimistic. I think, we have good vaccines here. They're protecting against the UK variant. We will have to make modifications for the South African variant. We've got a plan in place in the US to vaccinate the nation. It may not happen as fast as I'd like it, but I think by the summer and certainly by the fall, I don't want to say things will be completely normal, but we'll have a much better comfort level. As it is, I think you're going to start to see over the next few months things start to get a little better. We may get worse before it gets better because of the UK variant. So we have to ask the American people to be patient yet again. But we will we'll be in a by next year at this time, we'll be in a much better place. And even in a few months, I think we'll be in a much better place. So we have a lot to be optimistic for. What I'm more worried about is what happens in Latin America and Africa as the South African variant races through and we have so few options, and trying to prevent that kind of massive slaughter in the world's low and middle income countries is something that's keeping me up a lot. I am worried about the US over the next few weeks until we have this awkward transition where we're starting to get vaccine hubs open, but we may not have the full supply until June. So I think this is going to be one of the toughest times now, is how we get through February, March, and April.
We have about 10 minutes left in our conversation today. And so I just want to ask you, is there anything that you really want to make sure that the audience knows, or any message that you want to get across that we might have missed?
Well, I'll just say, speaking to the California Immunization Coalition, and I might have to jump off a few minutes earlier than the top of the hour. Just, you guys are heroes, and, for what you're doing to get the people of California vaccinated. I know this is not an easy state to be a vaccinator. There's a pretty, as aggressive anti-vaccine lobbies go, California's near the top, as is Texas, where I am, and Oklahoma, and maybe Colorado. These are tough states, and Utah's pretty tough also. These are in Oregon. So the western part of the country is a tough place to be a vaccinator. And I'll just say, just to remind you something you should know, but you may not, and that is you're all heroes for your role in trying to vaccinate the people of California.
Thank you.
Dr. Hotez, thank you so much for your time. It is extremely valuable. Thank you for everything you are doing. You have been a huge a warrior in this struggle, and as far as getting the word out to the population and speaking in a normal tone to our families and our patients and our communities, we thank you for everything that you have done. We hope, Dr. Hotez, that you will join us for our next COVID conversation, which will be featuring some of our local public health workers who will be talking about how they set up their local vaccination centers, kind of an on-the-ground look at how we are vaccinating patients one at a time. That'll be done sometime in mid-March. Our exact date will be decided.
Yeah, no, I look forward to that. These are moving goalposts, right? And, I look at some of the things I've said 6 months ago, and I said, oh, I can't believe I said that. And that's what happens, with a new virus pathogen. Pandemics with new pathogens set you up to make you look bad, try to be. And one of the things that I try to do, and when I speak, is to kind of lay out the assumptions I use to make these statements, and I think that's helpful, because every now and then you're wrong, but at least you can go back to the assumptions and say, well, this is why I said that 6 months ago, because this is what my understanding of the virus was. And then if it changes, then people understand that as well. So I think this is an important part of science communication. We tend to try to we make two mistakes as science communicators. One, we lapse into too much jargon and people don't know what the heck you're talking about. But the more common mistake actually is this, and we saw it, I think, a lot with the White House Coronavirus Task Force last year. Somebody in an office of communication said you have to talk to the American people like they're in the 4th grade or 6th grade, and that was true before something called the internet came along and everything else. And I think people are a lot more sophisticated now, and so being able to explain science and make straightforward statements and provide the assumptions, I think people like hearing it, and I think it makes you a more effective communicator.
Well, thank you for everything you do with regards to your communication. We are going to let you go, and then for everyone on the call, a evaluation will be sent to you shortly after. These conversations, this and our first two, are all videotaped, and you can find them on our YouTube channel or on our website. And again, we will post our next conversation, which will be in mid-March, on the California Immunization Coalition website. Again, Dr. Hotez, thank you so much for joining us. This was a wonderful hour that went really quickly. And again, thanks for all you do.
Thank you, and good luck to everybody. Bye-bye.
Thank you very much.